And we speaking about the management of ovarian cancer. So I invite Ramesan to come to that. This introduction of the speaker by our secretary.
Good evening, respected senior members and colleagues. My duty is to introduce the speaker of the day. Dr. Ramesan Cme is from Kannur, and he graduated. His MBBS is from Calicut Medical College, 943rd batch, and subsequently he did his MS in Obstetrics and Gynecology from prestigious All India Institute of Medical Sciences, Delhi, and subsequently he pursued a MCH in Gynec Oncology from prestigious Christian Medical College, Delhi. And previously, after his PG, he worked as a junior consultant in government health services. Subsequently, he joined as assistant professor in medical education service. And currently, he is working as a consultant in Gynec Oncology at Rationale. And above this, he is the younger brother of our Honorable Secretary, Dr. Rajmohan. And above all these, he was my roommate for the entire MBBS period. Thank you, and we will listen to Dr. Ramesh.
Respected senior doctors and other members of Kannur Ima. I'm very thankful for Kannur Ima for giving me this opportunity. Now I will come to the topic. Ovarian cancer. We in gynecological oncology have three main cancers: ovarian cancer, endometrial cancer, and cervical cancer. There is a lot of progress being made in the treatment of all these cancers. But one thing about ovarian cancer is, even though there is a lot of progress in understanding the pathology, the treatment, chemotherapy, medicines, but still the survival and mortality, mortality and morbidity hasn't changed much over these years. Ovarian cancer is still a mystery for the oncologists. Ovarian cancer is the second most common gynecological cancer in the number of deaths caused. And the problem is ovarian cancer usually presents in the very advanced stage. Even at that stage, most of the symptoms are very non-specific. The usual treatment is debulking surgery followed by platinum-based chemotherapy. And there is like very good response for the chemotherapy and surgery, but still most of the cancers, around 80-90% of ovarian cancer recurs in 2 to 3 years. That is the problem with ovarian cancer. Now, in this presentation, we're discussing a little bit about the history, the usual symptoms and signs. And in ovarian cancer, there are two scenarios. One is an ovarian mass, just an ovarian mass detected either incidentally or by an ultrasound done for some simple reasons. There is an ovarian mass. Another scenario is an advanced ovarian cancer. So I will discuss how do we approach these two kind of issues. and little bit about the treatment of recurrences also. First successful ovariotomy was conducted in early 1800s by McDowell. In this book, he has written this one patient, Miss Crawford. She was mother of five and was having an unusually long pregnancy. She wasn't delivering. And then this patient consulted McDowell and he diagnosed an ovarian tumor. He wrote only relief you can hope for is an operation that will remove the tumor, but I have never removed such a tumor. And he wrote he didn't know anyone who has done that surgery also. And at that point of time, any surgery, laparotomy was almost inevitable death. But this patient wanted surgery, and this surgery took place in McDowell's kitchen on 1809. A big mob waited outside his house to hang the doctor upon his patient's sudden death. But luckily, the patient he completed the surgery, and the patient and the doctor survived the operation. Now coming to the symptoms and signs of ovarian cancer. As I already told, early stage cancer is usually very asymptomatic and usually detected by an ultrasound done for some minor complaints. When it becomes advanced, the symptoms are again very non-specific, like lower abdominal discomfort, early satiety, loss of weight, loss of appetite, some pressure symptoms on the bladder and rectum. And the signs which we can see are sometimes, very rarely, patients can have a left supraclavicular node. Many times patients will present with dyspnea and pleural effusion, dyspnea due to pleural effusion. They will have ascites, umbilical nodules, and deposits in the pouch of Douglas, which is called Blomer's shelf. That is how it presents. Now, looking at the risk factors, there are many risk factors that we can modify. There is nothing much we can do about all these risk factors. The only thing which is important is the genetic factors. Around 5 to 10% of ovarian cancer is hereditary, and there are two important genes associated with this hereditary cancer. One is BRCA gene, and another is HNPCC gene. These are the two genes which are associated with ovarian cancer. And among this, BRCA is a common gene which is mutated. So BRCA1 is associated with the breast cancer risk of around 60% and ovarian cancer risk of around 40%. A little less with BRCA2. So what is the importance of knowing this genetic risk? One thing we can do is if somebody is having a mutated gene in their family, then we can offer them prophylactic surgeries. For the ovarian cancer, we can do by bilateral salpingo-oophorectomy by around 35 to 40 years of age, and this will reduce the risk of ovarian cancer by 90%, and the breast cancer by 50%. This Angelina Jolie is the first famous Hollywood actress. She did both the surgeries, bilateral salpingo-oophorectomy and bilateral mastectomy, because her mother died of breast cancer and she was diagnosed to carry BRCA1 gene mutation. And her estimated risk was 87% for breast cancer and 50% chance of ovarian cancer. So she underwent the surgery, and then this BRCA gene and this prophylactic surgery got very famous with her, this act of. Now I will little detail about what are the main types of ovarian cancer. So in this picture we can see there are mainly 4 types of ovarian cancer. One is the surface epithelial cancer, which is the most common type. Another is germ cell tumor, which originates from the germinal follicles. And then there is stroma. From the stroma, there will be sex cord stromal tumors, which are hormone secreting. And around 5% of the tumors are metastasis from other sites like GI tract, breast, and lung. Ovarian cancer usually spreads by the peritoneal, it spreads through peritoneal dissemination and direct extension. little less commonly through lymphatics and hematogenous spread. So even in advanced stages, ovarian cancer is usually confined to the abdomen. It rarely metastases outside the abdomen. So now I will come discuss regarding the management. As I already told, there are two scenarios. One is an early ovarian cancer and advanced ovarian cancer. So when we see an adnexal or ovarian mass, what are the clinical questions that we have in our mind regarding the management? The most important thing is, is this a simple benign cyst? Can we keep this cyst under observation, or does she need surgery? Another important thing is, if the cyst is not functional or physiological cyst, but then whether it is benign or malignant. Another important question is, can we preserve the fertility in young patients? Another important issue is, can we do laparoscopy for this ovarian cyst? If it is, another issue is to do whether do surgery by vertical incision or a transverse incision. So the problem with the an asymptomatic simple unilocular cyst, which is less than 5 or maybe around 7 centimeter in diameter with a normal serum CM125 levels, this kind of cyst can be kept under observation, and a repeat evaluation maybe by 2 to 3 months or maybe around 4 months can be done, and such cysts can be left alone. So which are the cysts that need surgery? Any ovarian cyst which is on during observation, it is increasing size, or the ovarian cyst contains solid lesions, or any papillary vegetations inside the cyst wall, any cyst which is more than 10 centimeter in size, or any cyst which is associated with ascites, or when there is torsion or suspected rupture in the ovarian cyst. So this kind of cyst needs surgery. So how do we differentiate between a benign and malignant ovarian cyst? And when there is only a cyst alone, how do we differentiate? There are different techniques. One is tumor marker. The most important tumor marker that we use is CA125. The normal cutoff is 35 in postmenopausal women and 200 in premenopausal women. Then the first line of investigation imaging is ultrasound, a transvaginal as well as a transabdominal ultrasound. Then there are many scores which helps in differentiating, combining this ultrasound and tumor markers. One is RMI score, another system is IOTA, and then even after all these things, during surgery we can do frozen section to differentiate whether it is benign or malignant. So little bit detail about RMI score. RMI score is a score which is we get by multiplying the menopausal status. Menopausal status becomes the score is 3 and premenopausal is 1. Then there is an ultrasound score. This ultrasound score is calculated by using 5 parameters. One is multilocularity, solid areas, bilaterality, ascites, and intra-abdominal metastasis. So any of these, all these features are given 1 point each, and if there is only one feature, then the score is 1, and if there are more than one feature, then the score is 3. So then CA125. So we multiply all this together and get a score. If this total score is more than 200, then the chance of malignancy is high in that case. And if it is less than 200, the chance of malignancy is less. Another system that we use, which has come recently, is an international ovarian tumor analysis system, which is called IOTA. In this thing, there are 3 things. One is a simple description. Means there are some cysts which are very specific. So there is simple description for those cysts. Then there are simple tools to differentiate between benign and malignant. Then there is a logistic regression which using all these multiple parameters. So I will discuss the simple descriptions. So a unilocular tumor with ground glass echogenicity is in a premenopausal woman is endometriosis. A unilocular tumor with mixed echogenicity and acoustic shadowing is in a premenopausal woman is a dermoid or a teratoma. Another simple description is a unilocular anechoic tumor with regular walls less than 10 centimeters, usually a serous cyst adenoma. So these are the simple descriptions. So first we look for the simple descriptions whether to diagnose these tumors, endometriosis, teratoma, and simple serous cyst. Then there are some simple description for malignancy also. A tumor with ascites and good color, blood flow in the mass is usually cancer, ovarian cancer. So these are the simple descriptions. I will show the pictures. Another simple description is a hemorrhagic cyst. So this is a hemorrhagic cyst. In this picture, we can see a reticular pattern. In this first picture, we can see the reticular pattern. And if you do serial ultrasound, this hemorrhage inside the ovarian cyst retracts and will form concave or convex margins, which is we can see in this other pictures. So this kind of picture on serial ultrasound is suggestive of a hemorrhagic cyst. Another, this is already I discussed. This is a dermoid cyst or a teratoma, in which we can see this white lines, which are hair which is seen inside the tumor, and the white is the calcified part in the dermoid. This is, and in the last picture we can see the floating echoes, which are fat inside the dermoid. So this is again a typical picture which we can diagnose as dermoid cyst. Now this is, as I already told, endometrioma, a simple cyst with ground glass echogenicity is endometriosis. So there is no doubt in this kind of ovarian cyst. Now there are simple rules for benign and malignancy. So there are 5 rules for benign. One benign, all the benign rules are unilocular tumor. If there are solid components on the cyst wall, in this picture we can see a small solid component which is very small. If it is less than 7 millimeter, again it is benign. Presence of acoustic shadowing, again feature of dermoid, benign. Then multilocular tumor, smooth multilocular tumor which is less than 10 centimeter, and on Doppler there is no color flow in the cyst. Again it is feature of benign. So if all these features are present and no malignant features are present, then it becomes benign cyst. And then the features for malignant cyst, an irregular solid tumor, presence of ascites, at least 4 papillary structures inside the cyst, or when the multilocular solid tumor is more than 10 centimeter size and a very strong color flow. These 5 features are suggestive of malignancy. So a tumor is classified as benign if only benign features are present, and is classified as malignant if only M features are present. So that is how differentiate between these two systems. So how do we decide whether to do laparoscopy for an ovarian cyst or should we do laparotomy? So current standard is for almost every malignant tumors, the standard is to do laparotomy. So we have to exclude malignancy before doing a laparoscopy. And even when we excluded malignancy, still we cannot be 100% sure. So even during laparoscopy, we have to make sure that the cyst is not ruptured during surgery. So that some methods like we can use open trocar insertion or a left upper quadrant entry can be tried. And while removing the cyst also, we have to be careful that the cyst contents are not spilled into the abdomen. It should be removed in a bag or through a mini laparotomy. Which are the cysts which needs a referral to a specialist? If there are features of advanced malignancies, it may be better to refer to a specialist. What are the cysts or what are the ovarian cancer in which we can preserve the other ovary or fertility? There are some specific situations. Patient should be young and should be very motivated for preserving the ovaries. Dysgenetic gonads should be ruled out. So the situation that any unilateral germ cell tumor, any unilateral stromal tumor, any unilateral borderline tumor, or a stage 1A invasive epithelial tumor, in all these situations we can preserve the other ovary and uterus so that the patient can conceive later. I'm not going to the details of staging, but ovarian cancer staging, there is 4 stages. Stage 1 is a tumor which is confined to the ovary. Stage 2 is a tumor which is confined to the pelvis. And stage 3 is a disease which has spread to the upper abdomen. And stage 4 is a disease which has gone out of the abdomen. So what are the factors that are important in the survival? As obviously stage is important, histology and grade of the tumor is important, but we cannot change all these things. These are not in our control, but only thing that we can control is the residual disease after surgery. So any residual disease which is more than 1 centimeter after surgery, that kind of surgery is as good as no surgery. So our aim is to remove all the gross macroscopic tumor during surgery. If you look at the problem, survival by stage, we can see stage 4 has a 5-year survival of just 11%, and stage 3 is also, the survival is not good, 41%. So in ovarian cancer, what are the steps in the surgery? Initially, we have to take a peritoneum. If there is on laparotomy, the tumor is not extensive, then we have to do a staging laparotomy. If there is on opening, we see it's an advanced disease, then the surgery is called a debulking surgery. So we have to evaluate the peritoneum as well as the abdomen to see the extent of disease. We have to evaluate the pelvis, peritoneal surfaces, diaphragm, omentum, lymph node, bowel surface. Everything has to be inspected first. And the surgery is to remove all the macroscopically visible tumor. Our aim is to achieve no macroscopic tumor at the end of surgery. All these complex surgeries like bowel resection, diaphragm stripping, peritonectomy are good only if we can achieve a complete cytoreduction. And the intent of initial treatment is always curative. What are the benefits of doing a cytoreductive surgery? So when there is big tumor load inside the abdomen, there will be a lot of resistant fronts of tumor cells, and it will not be sensitive to chemo. So we have to remove all the resistant fronts of tumor cells. When we remove large bulk of tumor, then the rest of the tumor cells enter into the growth phase, and such kind of, when there is increased growth pattern, they will be more chemosensitive. There is reduced risk of drug resistance, improved tumor perfusion. So after surgery, all these factors will help in clearing, make the patient more chemosensitive. In advanced cancer, what are the clinical questions that we have to answer? One is, which is the best imaging for advanced ovarian cancer? What is the best treatment, whether to do a primary debulking or a neoadjuvant chemotherapy? What is the role of routine lymphodeplectomy in advanced cancer? Which is the best chemotherapy? And which are the patients that we can avoid chemotherapy? What is the role of intraperitoneal chemotherapy? The role of maintenance chemotherapy? These are all the questions that we have to answer when we manage an advanced ovarian cancer. So, as I already told, for an ovarian cyst, ultrasound is the first line of investigation. But when we suspect an advanced ovarian cancer, then for staging, CT, abdomen, thorax, and pelvis is the imaging of choice. But sometimes when there is confusion regarding the ovarian mass, whether it is endometriosis or whether it is malignant, in such kind of cases, confusion after an ultrasound, we can do an MRI to characterize ovarian cyst. PET CT is usually used in recurrent settings. So the treatment options for an advanced ovarian cancer are two types. There are two kind of treatment. One is to do a primary cytoreductive surgery, which includes removal of uterus, ovaries, lymph nodes, and other tumor deposits, followed by adjuvant chemotherapy. Another is to give chemotherapy after 3 cycles with interval cycles. So, which is better, to do a primary debulking or interval debulking? Interval means giving chemotherapy and then doing the surgery. So it was there is not much randomized control trials on this subject. Recently, there are 2-3 randomized control trials. So primary debulking was initially thought to be having a better survival, but it is always associated with increased morbidity and mortality. Neoadjuvant chemotherapy was associated with less mortality because the disease load become less after the chemotherapy, so a less extensive surgery can be performed. But again, it was thought that it has an inferior survival. So how do we select patients to primary debulking or a neoadjuvant chemotherapy? So there are different things. One is imaging. Another way is to do laparoscopy. Then other factors which also comes into consideration are the performance status, patient's nutritional status, comorbidities. So I'll go in little detail. So we can use modified Charlson's comorbidity index. This is how many comorbidities the patient is having, and each one is given scores. So when there are multiple comorbidities and the score is more than 3, even the patient after there is a very high mortality with primary debulking surgery. So when there are multiple comorbidities, it is better to give neoadjuvant chemotherapy. Another is called a frailty index. Frailty, again, the same thing, but this frailty is the patient's ability to tolerate an aggressive treatment approach. So when the patient is more than 75 years and the performance status is ASA more than 3, nutritional status, albumin is less than 3, all this makes the patient frail. And such a patient, even if we do an extensive surgery and clear all the tumors, they are not going to benefit from the surgery. The morbidity will be very high. Another index which is used is peritoneal carcinomatosis index. Abdomen is divided into 13 areas on the CT scan, and each area is given a score based on the size of the tumor deposit on that area. So a total score is calculated, and the score which is more than 60 or more than 20 is associated with incomplete cytoreduction and poor survival. So when we do CT scan and score according to this tumor deposit in each area, when the score is more than 16, we can send that patient for chemotherapy first and later do the surgery after 3 cycles. Another way of assessing is to do a diagnostic laparoscopy at first phase. So the score is called a Fagotti score, where we look at different areas like peritoneum, diaphragm, mesentery, omentum, bowel, stomach, and liver surface. In this method, we have to use a proper incision. This is drained first, adhesive lysis is done, then we inspect the whole abdomen and give a score, and the whole score is added together to see whether we can operate or not. So in this picture, we can see the peritoneum. In the first picture is 0, and when there are a lot of tumor deposits on the peritoneum, it is given a score of 2. But when the diaphragm is showing tumor deposits, it's again score of 2. Omentum becomes a cake with tumor, again score of 2. In this bowel is showing a lot of tumor deposits. In this picture, we can see surface tumor deposits on the stomach. Again, on the surface tumor deposits on the liver. So when we add all these scores together, and if it is more than 8, then again that patient is not a good candidate for primary debulking surgery. Such patients can be sent for chemotherapy and interval debulking surgery. So what is the current evidence and current consensus? In latest Cochrane review, it is shown that there is in advanced ovarian cancer, there is no difference in primary survival outcome between primary surgery or a neoadjuvant chemotherapy interval debulking surgery. But neoadjuvant chemotherapy reduces the risk of serious adverse events at the time of surgery and in the immediate postoperative period. And it also reduces the need for bowel resection and stomach formation. These are all the indications for neoadjuvant chemotherapy. There are 2 situations. One is when the tumor is too much that it is difficult to cytoreduce to non-cerebral tumor, or when the patient has multiple comorbidities, or when the nutritional status is poor, so that such an explicit surgery patient cannot tolerate. If we are doing a primary debulking surgery, what are the procedures which we need to do to attain complete debulking will be something like radical momentectomy, sometimes bowel resection and anastomosis, and lymphadenectomy. So a radical oophorectomy procedure is called a Hudson's procedure, in which we will remove the ovarian tumor along with uterus, pelvic, peritoneum, and sometimes the involved part of bladder and bowel. So this is called Hudson's procedure. Peritonectomy may be needed in some cases. We have where it is involved peritoneum has to be removed. Bowel resection, again, before doing a bowel resection, we have to assess the whole situation, and we have to assess whether we can achieve a complete cytoreduction. Only if we can achieve complete cytoreduction, then only we should go ahead with the bowel resection and anastomosis, or bowel resection and so on. What is the role of lymphadenectomy in advanced cancer? There is no role for routine removal of all the lymph nodes in advanced cancer. Only the enlarged nodes has to be removed in advanced ovarian cancer. Another recent concept is hyperthermic intraperitoneal chemotherapy. In this, after the primary debulking or interval debulking surgery, when there is no tumor inside, no closed tumor inside the abdomen is chemotherapy fluid, which is heated to 42 degrees Celsius, and it is circulated for around 90 minutes. The chemotherapy agents usually used is cisplatin or oxaliplatin. So this is a kind of regional therapy, and it allows high dose of chemotherapeutic agent to be kept in the abdomen, a kind of local therapy. And it is called that when the temperature is around 41 to 43 degrees Celsius, it has a tumoricidal effect. There are two kind of hypec. One is an open abdominal technique, in which after the cytoreduction is complete, the abdomen is kept open, and chemotherapeutic fluid is circulated for around 90 minutes. The potential problem is occupational exposure to the chemotherapeutic agent. Another method is to do a closed abdomen technique, where drains are kept for inflow and outflow. The current evidence for hypec is not very good in ovarian cancer. So currently there are many centers performing ovarian cancer. Now, little bit about adjuvant chemotherapy. The standard adjuvant chemotherapy for ovarian cancer is carboplatin. The standard of treatment is carboplatin and paclitaxel for 6 cycles. So there are some patients in which we need not give chemotherapy. That is when it is a stage 1A low-grade ovarian epithelial ovarian tumor, or some histology like mucinous tumor stage 1A, or endometrial tumor stage 1A. These are the tumors where we need not give chemotherapy. They can be just kept under observation. All the other patients will need chemotherapy with carboplatin and paclitaxel for 6 cycles. So there are two more new agents, targeted agents. One is bevacizumab. It is an angiogenesis inhibitor. So this bevacizumab is given in advance when there is stage 4 disease, or when there is very large volume ascites, or when it is difficult to do a complete cytoreduction, when the patient had a suboptimal cytoreduction. In all these patients, this bevacizumab, an angiogenesis inhibitor, is found to improve survival in this kind of patients. Another drug which is recently in the way is a PARP inhibitor. PARP inhibitor is a tablet. This drug acts on DNA repair mechanism, and now PARP inhibitor is being given in It is mainly useful in BRCA mutated patients. It is given for first line maintenance of BRCA mutated ovarian cancer, and it is also given in the treatment of recurrent ovarian cancer. So this is a new oral agent which can be given for maintenance as well as recurrence. So after the initial treatment, the patients are classified into 4 groups based on their recurrence or progression. A patient is told like platinum sensitive when the recurrence is coming after 12 months. It is called partially platinum sensitive when it is after 6 months of treatment. Patient is called platinum resistant when the recurrence occurs within 6 months of treatment. And patient is platinum refractory if the patient progresses on chemotherapy. So how do we diagnose these recurrences? The questions are like how do we diagnose, what is the intent of treatment? So when there is recurrence, the intent of treatment is mainly palliative and to prolong progression-free survival and overall survival and to alleviate symptoms. It is very difficult to cure a recurrent ovarian cancer. Another important issue is most of the time after the initial treatment, patient will have some side effects like neuropathy and all. Then such patients may not be fit for the similar kind of chemotherapy. So that is another issue. Other issue is cost. This new agents like bevacizumab and PARP inhibitors are very costly. That is another issue. So for diagnosing recurrence, the follow-up schedule is standard for all the cancers, like 3 monthly for 2 years, 6 monthly for 3 years, yearly thereafter. We have to do clinical history and history and clinical examination to look for any evidence of recurrence. Tumor marker which is used for follow-up is CA125, and PET-CT can be done to see whether it is a localized recurrence or an extensive recurrence. Regarding treatment, if the patient is platinum sensitive, such patients can be offered a secondary cytoreductive surgery and they can be rechallenged with platinum. Platinum refractory and platinum resistant tumors are not good candidates for surgery as well as the chemotherapy. They should be enrolled in clinical trials and they should be given early palliative care. So coming to secondary cytoreduction, so which are the patients who deserves a secondary cytoreduction? One score which is recently came is a AGO score. There are 3 parameters in this score: a good performance status, there is no ascites, and complete cytoreduction should be done during the first surgery. So if all these 3 parameters are present, and such patients can be offered a secondary cytoreductive surgery. Again, in secondary cytoreductive surgery, the survival is improved only if we can achieve complete cytoreduction. Another important issue in ovarian cancer is bowel obstruction. Bowel obstruction is usually a terminal event, and the aim of surgery is usually palliative. But many times, even diversion with resection and stoma is not possible because most of the bowel will be like segment will be completely involved, so that we cannot get a segment which we can divert. Coming to germ cell tumor, just one slide about germ cell tumor. Germ cell tumor is a tumor which occurs in young females, usually in the 2nd and 3rd decades. And we have 3 tumor markers for that: LDH, alpha-fetoprotein, and HCG. In germ cell tumor, the most important thing is to try fertility preservation, because these germ cell tumors are very highly chemosensitive. So we can, if the one ovary and uterus is not involved by the tumor, we can leave that uterus and ovary. Even if there are deposits in the peritoneum and omentum is involved, we can still preserve the uterus and other ovaries so that fertility can be preserved. And the chemotherapeutic agent used in germ cell tumor is bleomycin, etoposide, and cyclophosphamide regime. Not it's carboplatin paclitaxel is not the regime. It's daily regime which is used to them. So with this, I will finish and thanks for the patience. Only patients who
if you can treat properly, if you do it with the proper should not be. It is focusing with the treatment itself. This is more aggressive.
yes, sir. But what is screening base? Even if you do 3 monthly scans for ovarian screening for ovarian cancer, still physicians are being listed such kind of harassment because ovarian cancer starts in very short duration of time. Like even patient does a normal scan and within the next 3 months they are having advanced cancer. So screening is not very good for very high patients who are we are saying with this.
In the case, and her genetic study exposed that she has got a 9% chance for breast cancer. So she has done mastectomy first, and then after examination, genetic study, there is a paper that's for ovarian cancer. So she removed all. So this is the recommended. You see, when there is a breast cancer, early detection is very easy now. You can do a partial mastectomy, you can spare the breast. So even they said that it was just for some advertisement of the hospital case. So a lot of
mastectomy is usually not very much recommended. Ovarian cancer screening is very difficult. Ovarian cancer, breast can be easily screened and mastectomy is not very much necessary.
The idea of study is medical genomics. One of the emerging branches of testing. But as I mentioned, there will not be an aggressive therapy, but knowing things that each type of patients can be reduced or improved, so some patients can be. Not in gynecology, even in cardiology, nephrology, many other specialties, medical genomics. So I think recommended. But the thing is, it gives some reason. So nowadays, this study, even with the nowadays, the single genome for 2 to 3 genomes, I think 3,500 can be done. So that's an emerging area that should be support.
Hello, doctor. This is Dr. Akbar here. Hello. Can you hear me? I'm Dr. Akbar. Am I audible? Am I audible? Dr. Akbar here. Hello. Am I audible?
Yes, sir.
Yeah, I lost my sister to CA ovary. Is there any method you can find out as very early detection? Is there any special method, or do you advise C125 from a particular age? Will it help?
There is nothing is recommended for nothing is proven for early detection. There is no recommended method for early detection.
I mean, there is no method.
There is.
I mean, do you advise C125 estimation from a certain age or something?
Yes, sir. 25 transvaginal scan, and multiple combined methods have been tried. All these methods are useful only in very high risk patients, like this genetically when we are CA mutated patients. Not in general population, there is no recommended method for screening.
But you don't advise one C125 routinely.
Not, sir.
Hello. Some problem in the audio.
Sir, we can hear, sir. We can hear you, sir.
Can you hear me?
Yes, sir.
Am I audible?
Yes, sir.
Your voice is not clear. That's why I don't know whether you are really getting me.
Sir, I understood the question.
Hello.
You are asking.
Yeah.
You are asking regarding screening methods in normal population, no, sir?
Yeah. No, not normal population. Is there any method? Will it help if you do a C125 estimation from certain age?
Yes, sir.
For women?
It is recommended in patients with family history or BRCA mutation, non-BRCA mutation, not in the general population, sir.
I see. I mean, you don't have to do it from a certain age. That won't help, is it?
If the patient has a family history of breast cancer or ovarian cancer, or if they are already known to have BRCA mutation, such patients are recommended CA125 screening and TBS from 35 years of onwards.
35, is it? Okay.
35.
That's the age I wanted to know.
Yes, sir. Yes.
Thank you, doctor.
Thank you.
Very excellent speech. Very useful also.
Thank you, sir.
Thank you.
Yes, sir. Robotic surgery is currently, this minimally invasive surgery is being used in endometrial cancer for staging and treatment. In cervical cancer, recent study has come out and which says minimally invasive surgery is having a poorer outcome compared to open surgery. So for cervical cancer surgery, currently the standard is open surgery. For ovarian cancer, the standard is open laparotomic surgery, but in like after neoadjuvant setting, like interval debulking and all, people are trying robotic and minimally invasive technique. See, endometrium is the standard. Robotic or laparoscopy is the standard. Sir, inoperable, like in the first setting, then we usually give chemotherapy, and after 3 cycles, we'll see whether they are being operable or not. Even after 3 cycles of chemotherapy, patients are still being inoperable, means they are not chemosensitive. Such patients will not benefit from surgery. And ovaries will give birth to stage so that we the process. Yes, sir. Yes, sir. Yes, sir. Yes, sir. The treatment should never be more worse than the disease. That is the primary objective. Yes, sir. We are going against this. Yes.
Next is vote of thanks to the secretary.
On behalf of the Kannur IMA, I express our sincere thanks to Dr. Ramesan CK for his excellent and informative talk on ovarian cancer. Also, I thank all senior members of the Kannur IMA and also our dear friends for attending today's meeting. Our sponsors for today's meeting is Metropolis Lab. I also thank for their sponsorship. Thank you. Jai Ima.
ಇಲ್ಲ ಸ್ವಲ್ಪ